Please start, Professor Mapa.
Okay, ready to go. Thank you so much, Nidhi. Good afternoon, everyone. My name is Joe Mappa, and on behalf of the Krembil Center for Health Management and Leadership and Detlef Zwig, Dean of the Schulich School of Business, I want to thank you for joining us today. This is our 8th summit, and we're delighted with the level of participation. I feel we're resonating, which makes me feel very, very good, and all of us at the Krembil Center. Our theme today, the future of primary care in an era of AI and smart technologies, reflects our center's ongoing focus on the growing role of artificial intelligence and machine learning as critical drivers of healthcare innovation. We believe there's an urgent need to educate healthcare leaders on the opportunities, the challenges, and responsible integration of AI, ensuring they are prepared to adapt effectively. Our goal today is to provide a better understanding of AI's role in primary care because strengthening primary care is essential to addressing Canada's long-term healthcare challenges. A recent report by the Partnership for Healthcare System Sustainability and Resilience, a global collaboration of academic, non-governmental, life sciences, healthcare, and business organizations, concluded that primary care reform is crucial to rebuilding Canada's crumbling healthcare system. The report emphasizes the need for an immediate overhaul of how primary care is governed, funded, and organized. It goes on to say, most importantly, that investing in team-based models would clearly define roles and scopes of practice for healthcare professionals, including family physicians, nurse practitioners, and specialists, can improve access to integrated care, reduce wait times, and enhance system efficiency. AI and machine learning are indispensable tools in driving this transformation at every level, including support for clinical decisions, personalized treatment plans, reduced administrative burden, and the use of data for varying purposes. To fully realize the benefits of this technology in strengthening primary care, we must focus on their implementation, ethical considerations, and long-term impact. Invited 3 distinguished thought leaders to share their insights. Our moderator, Dr. Abhi Sriharan, will provide additional context and introduce our speakers. Dr. Sriharan, Abhi, is a senior scientist at the Krembil Center, whose research, publications, and global impact are shaping the center as a hub for AI excellence in healthcare. We are particularly proud of her most recent article in the International Journal of Health Planning and Management entitled Artificial Intelligence in Healthcare, Balancing Technological Innovation with Health and Care Workforce Priorities. Over to you, Abhi.
Thank you, Joe, for this vision to keep these kind of programs run out of Krembil Center. And I think that's like the audience is a testament that forums are really working. So I just wanted to welcome everyone for today's panel, which is focused on the future of primary care in the era of AI. We have been talking about AI a lot, so let's think about how AI and primary care meet and what are some of the issues. So we are going to talk about something that matters deeply to all of us, how technology is changing the way we deliver and experience primary care, and what that means for people, providers, and the health systems. Primary care is the heart of every health system, but in primary care providers isn't always easy. In fact, in 2023, we had about 4 million Canadians didn't have access to a primary care provider. However, on the other hand, the research shows that when people do have access to a primary care provider in Canada, the experience is overwhelmingly positive compared to many OECD countries. Canadians say they have the providers who listen to them, who explain things to them, and who involve them in decision making. So how do we bridge the gap between the need and the strength that we have in our primary care? What can technology do to help us? Tools like virtual visits, AI-powered decision supports, and automated charting offers exciting possibilities. They can save time, reduce stress for providers, and help deliver more accurate and personalized care. These innovations could help us close the access gaps, especially in rural and underserved communities. But like any big change, this comes with risk. studies have started to show that unintended consequences lies when these technologies are adapted without strategy. So today's panel, we are going to ask some big questions. How do we make sure this technology helps rather than hurts the human connection in primary care? How do we strike a balance between using AI to be more efficient while still keeping care personal and compassionate? And how do we support our workforce to make sure that our providers who are essential to make all of this work are thriving? This balance between speed and thoughtfulness, innovation and care is exactly what we are going to explore today. So let me introduce, we have three great panelists, and I will introduce each panelist, and then I will invite them to share some of their opening remarks. And after their opening remarks, we will open up for discussions. So first panelist is Dr. Trish Greenhalgh. She's a professor of primary care at the University of Oxford and a leader in primary care globally. And she has done a lot of work around digital transformation, innovation, disseminations. And for her work, she has been recognized through numerous awards. I can't list all of them. It will take me the whole hour and a half. But she, I think one of the most important one is she was honored with the OBE, Order of British Empire, for her contributions to medicine. And she continues to write a lot about digital transformation technology. So, Trish, the floor is yours, and we'll open with your comments.
Okay, so thank you very much for inviting me. It's an honor to be here, and I'm pleased the technology so far is working. I've been asked to talk about challenges to building an evidence base. I just want to acknowledge my funders, but also two of my PhD students, one of whom is a postdoc now, Rebecca and Fran, whose work I will be drawing on a little bit. So let me confess how I started to prepare this lecture. I got onto Gemini, a large language model, and I asked Gemini to give me this lecture. What did it say? I got this beautiful list out. Isn't it wonderful? And I would suggest to you that this is the kind of bland and meaningless flannel that you get if you ask a large language model to tell you about AI in topic X when it has actually no understanding of topic X and also doesn't care about the truth. And we all know that one of the problems of AI is that it is indifferent to the truth value of what it is telling you. So I don't want to start with AI. I want to start in a very old-fashioned way by talking about what primary healthcare is. And I'm quoting here Dr. Julian Tudor Hart, who was a general practitioner in Glencorrig in South Wales. This was a mining village. And then when the mines closed, everybody was unemployed. It was extremely deprived and poor. And Tudor Hart said primary healthcare is doing simple things well for large numbers of people, few of whom feel ill. This paper he published in the British Medical Journal in 1982, I read as a final year medical student and it inspired me greatly. It's called Measurement of Omission. So he looks back to the 1960s and describes the birth of a child with congenital rubella to a very poor Welsh family who already had 5 children. And this child's very profound disabilities affected the whole family, as you can imagine. And he describes how the father became an alcoholic, got coronary heart disease, etc., etc. So he says, when rubella immunization became possible, we wanted it to succeed. And he said he asked for a list of the girls who had been immunized against rubella, and the medical officer of health said, I can give you the names of the ones that we immunized, but how can I know the ones we didn't? And this was the beginning of primary healthcare saying we need to keep records of our patients and we need to develop what Tudor Hart called anticipatory care. In addition to the reactive care of patient-initiated consultations, we need to set up registration, recall, and regular review, whether that's for immunizations, whether it's for calling people to have their blood pressure checked, etc., etc. And so you can see from this little vignette about this Welsh village how primary care moved from being just reacting to whatever patients brought in, to being proactively and anticipatorily responsible for a community. And we've seen that right around the world, in addition to being longitudinal, family-oriented, community-focused, and so on. And actually, some of you may be more familiar with the work of Barbara Starfield from the United States, who described primary care in these six descriptors: first contact, longitudinal, comprehensive, coordinated, family-centered, and community-oriented. And Starfield, as many of you will know, demonstrated in country after country that if we can tick all those boxes, we get lower morbidity, higher life expectancy, lower overall system costs, and better health equity. All right, I know you've come to listen about AI. So can I now put this question to you? I think the question we should be discussing today is, to what extent is AI able to support the delivery of first contact, longitudinal, comprehensive, relationship-based, coordinated, family-oriented, and community-focused generalist care? That is what primary care is. Can AI do it? The current context for primary care is very adverse. There is a global workforce crisis. It's not just you in Canada that have got these problems. They're worldwide. There is escalating demand. Perhaps there's also increasing need, but there's certainly more people knocking on the door. There are rising inequities. There are novel tests and treatments, some of which are very expensive. And there is a growing focus on risk factors and pre-disease. So I count that as one of the problems, actually. Maybe some of you think that's not a problem. We have a maladaptive response to that crisis. We have the fragmentation and taskification of primary care. We have a deprofessionalization of primary care, with more things being done by people who have limited qualifications. We have a technologization of care, including more and more remote services and digital services. And we have what I call the responsibilization of the patient. We push more and more responsibilities on people, some of whom are fine with it, some of whom can't cope with it. So now let's think about AI. What is AI good at? And I think AI is good at these things. It's good at automating highly routine tasks. It's good at pattern recognition. It's good at summarizing and redrafting texts. And it's also really good at ossifying and perpetuating our societal biases. There was this piece in the Financial Times a couple of weeks ago, which demonstrated that ChatGPT is simply not able to multitask. And that's why some people have still got their jobs. Now, this article was actually not about doctors, but do you know what? I think it could have been. So what is AI bad at? It's bad at multitasking. And that's actually what we doctors do most of the time, especially in primary healthcare. It's bad at finding and organizing new information. It's bad at adapting any kind of standard process to take account of the unique needs of the individual. And it's really, really bad at telling the truth or even caring whether it tells the truth. Now, I'm going to give you one slide to summarize 3 years' work and £1 million worth of money. We followed 12 UK general practices for 28 months, looking at digital innovation. You can email me and ask me about the details if you want. What we found was that apart from back office functions, for example, recalling people for their flu jabs, we didn't find any AI tools. Maybe if we'd kept going for another 6 months, we would have found the AI scribe tools, but that just missed our window. What we did find was many and worsening inequities in access to care. So let me take you back to the Welsh village and Julian Tudor Hart. You may have heard of the inverse care law, which he published in the Lancet in 1971. The availability of good medical care tends to vary inversely with the need for it in the population served. Having slight trouble moving my slides on. There we go. It's more than 50 years since he wrote that. And now there's some very interesting articles coming out about how the digital age may compound the inverse care law, and particularly in primary care, actually. I've written some of those articles, but the ones I've just clipped here are written by other people. Again, I'm having trouble moving my slides on. There we go. So the inverse care law in the age of AI, I've got a preliminary hit list for primary care. These are the problems, I think, which AI is compounding. Firstly, is the way we tend to deconstruct the patient into fragments, and each fragment is managed by the cheapest person or the cheapest technology who can perform a task. Secondly, instead of examining and treating the patient, the flesh and blood patient, we examine and treat what Fran Dakin calls the patient's digital facsimile, the stuff that is on the record, the answers that the patient has put into those boxes that they've had to fill out. And that is compounding the inverse care law. Thirdly, remote-only access, with the patient expected to follow algorithmic pathways and make judgments in real time. And if you've watched one of your relatives, your less digitally literate relatives, try and go through these commands, like select one if you are in emergency, you and I can do it, but actually a lot of people can't. And finally, the overshadowing of individualized relationship-based care by the one-size-fits-all AI-driven risk factor management. Now, some of these things will improve with better AI. Some of them will not. So just to summarize, again, this AI-generated outline for my lecture, which, as you can see, I did not follow. Automation of administrative tasks. Yes, I will buy that. There are a few examples. Reducing clinician burnout. No, no, no. We have found clinicians are seriously more burnt out through techno stress. We just published a paper on techno stress because of the fragmentation of care, because of the complexities of introducing new technologies. All this stuff about risk prediction. Actually, the main problem is access. The main problem is the sickest people, the ones with the most risk factors, simply cannot access primary care anymore because we've closed the digital front door in their face. Improved accuracy in interpreting medical images, yeah, that is sure, but we don't do that in primary care. AI-powered chatbots for patient support. That at the moment is vaporware. It's in people's heads. They're talking about it. I've never seen one that actually works. Potential to improve access to care in underserved areas. How? I've spent a lot of time in underserved areas in the last 3 years looking for this. I haven't found it. Do we need to use AI to identify and address health inequities? No, just use postcode. Postcode is a really good predictor. It's better than the entire sequencing of your genome. Just find out where you live. That will tell you about health inequities. And then clinical decision support. Yes, I'm open to actual examples here. I understand David's got a couple, but at the moment, it's not happening in UK. It's all still ideas and predictions. So I hope I haven't been too provocative. Thank you for your attention. I'm not on Twitter. I'm on Blue Sky if you want to message me. And if anyone wants to take a quick picture of that, those are some of the papers that have come out from the Remote by Default 2 study on the digitalization of primary care in the UK. There's a couple more to come, which are in press. So thank you very much. And I'm now going to stop sharing, if I can.
Thank you, Tricia. Could you like actually keep the last slide because there's some really gems of articles in that last slide.
Oh,
The
you
one
mean the
that,
slide with all my stuff on it?
yes,
Like,
so the QR codes, people can take a quick
oh,
QR
yeah,
code
sure,
of that
sure.
if they want to. The techno stress is an interesting one that you brought up. A recent paper, well written, articulates some of the challenges that we are seeing with burnout issues. Because the value proposition we see from AI is going to reduce burnout, right? So 30% of our workforce is burnt out. If 30% of these things will be automated with AI, and it's going to do wonderful things. But in reality, all of us researchers who are researching in this are seeing is it's actually AI is increasing the documentation burden, because now instead of getting a simple SOAP note, physicians and specialists are getting large volume of text
Yeah,
information, and
yeah.
someone has to actually now go and read through it and make sense of it. So can you just talk a little bit about technostress before we go to David?
Yeah. So the paper on technostress was Fran Dakin's work, and what she was mainly looking at was reception staff, back office staff, and how as technostress increased, team relations broke down. And some of you will know the work of people like Amy Edmondson, Jody Gittell. These are American researchers who have demonstrated time and again that if you're going to deliver a complex service, you need a team that gets on well with each other. You need positive team relations. And if using the technology damages your team relations, because of course, when you're stressed and when the phone's going all the time and when, all that stuff, you're grumpy with people, basically. And but what let me, because I think I've been quite negative about tech. And one of the things we did demonstrate over 28 months is that even the technologies that produce high levels of techno stress initially quite often produce less techno stress once people had got used to them and once they had sorted out the workflows, who was going to use it and how people were going to interact around it. And so I think one of the reasons why techno stress is so high is because people assume that these technologies are plug and play, whereas actually what you have to do is go through a process of adjusting the work process and the workflows to the technology and tweaking the technology in return. And so I think it's not as simple as technologies cause technostress. It's technologies cause technostress until they are properly embedded. And if they're still causing technostress, then you've got to disembed them. Then you've got to withdraw from that particular technology. But yes, this idea that they will reduce burnout, I haven't seen that. I really haven't seen it.
Thanks, you. Thank you. That's a really great introduction to the topic, and we will come back for more panel discussions. And that actually brings us to our next speaker, Dr. David Bates, who's a professor at the Harvard University, University of Oxford, Harvard University. And Dr. Bates is a world leader in patient safety and the use of information technology to improve care. So again, a different angle to look at thinking through technology from a patient safety perspective. And Dr. Bates has been widely cited for his work for improving healthcare quality and outcomes. And he currently co-directs a Center for AI and Bioinformatics and Learning Systems at Mass General Brigham. So David, the floor is yours.
Thank you so much. Okay, so I'm going to talk about the potential of AI in primary care, and I agree with many of the things that Trish has shared with you, but in some places we disagree. I've worked with several companies, none of which I'm going to talk about today. And I'm going to start with by providing a little bit of background. I'm going to give a more of a U.S. Perspective, and I'll talk about where I think primary care providers are now. And I'll talk about ambient documentation, and then I'll talk about several other potential interventions and some of the other ways that PCPs will be interfacing with AI, and then I'll wrap up. And I also believe very strongly that primary care is first, foremost, and fundamental, that it really is absolutely central to delivering good health care. And we are not in a good place either with primary care, and that primary care providers are burned out. They're tired, and they need to have some things go better. But I do think this is a place where that can happen. And just as a bit of backdrop, this is work that I've done together with Dr. Lisa Rottenstein. Administrative burden is substantially greater for primary care providers than for specialists, either medical specialists or especially surgical specialists. And in addition, our data show that administrative burden for PCPs has been increasing. And that's more true for primary care specialties, again, than medical specialties or surgical specialties. There is also data showing that primary care providers who spend the most time after hours on the electronic health record have higher odds of emotional exhaustion. That's work led by Dr. Julia Adler-Milstein that was published in JAMA in 2020. And in addition, spending over 90 minutes on EHR outside the workday by self-report, or more than 1 hour of self-reported clerical work per day, were also strongly associated with burnout, with odds ratios of around 1.4. So clearly there's a big problem here. And among 40,000 family physicians, appropriate home electronic health record time was associated with higher odds of burnout. And this burnout, has major effects. And this slide just shows the burnout rates amongst family physicians over the years. That figure appears to be going up. And in the US, 40% of physicians say that they're definitely or likely going to cut back on their clinical hours in the next 12 months. And a quarter of physicians say that they would definitely or likely leave their clinical practice in the next 24 months. So this is really affecting the way that people are looking at things. This is a study that we just did, however, on the impact of virtual scribes on time in primary care. And the main study sample included 144 unique physicians who'd used a virtual scribe for 3 months in 152 different episodes. Nearly 2/3 of the physicians were female, so 60% were female. A little more than half were in primary care specialties. And use of a virtual scribe was associated with significant decreases in total electronic health record time per appointment. And scribe use was also associated with significant decreases in note time per appointment and pajama time per appointment. By pajama time, we mean time at night when you after going home. And in a multivariable linear regression model, the following factors were associated with significant decreases in total EHR time with scribe use at 3 months, practicing in a medical specialty, greater baseline EHR time per appointment, and decrease in the percentage of the note contributed by the physician. There's just like an absolute explosion of different technologies which can help with ambient documentation, and many of these are not that great, but there's a variety of different categories. This comes from a market research company called Avia. They broke things down into ambient observation and monitoring, ambient clinical intelligence, ambient documentation, ambient assistance, and ambient experience. And I would say it's hard to know like which of these is really going to pay off, but I just want to make it clear that there's an explosion here, and I'm going to focus in particular on ambient scribes. Because that's what we have the most data with, and at our institution we put in place ambient scribes. We studied this at our institution and a second institution, and the burnout rates actually fell substantially, which is the first time we've seen something like that. And the proportion of physicians who said they were professionally fulfilled went up some. And similarly, at the other institution, the well-being rate went up, and ease of documentation also improved. So this is some of the first light that I've seen really at the end of the tunnel. And overall in this experience, this is the first thing that we've done that really reduced burnout rates. Patients were also happy with this process. The physicians reported reduction in burnout, and this is being rolled out rapidly in multiple institutions across the U.S. And it's particularly popular in primary care. This is a study that I published with Dr. Urmimala Sarkar from UCSF, in which we speculated about what are some of the ways that AI could be useful. And it's mostly for dealing with some of those repetitive tasks that Dr. Greenhall talked about. So things like prioritizing patient messages, generating draft responses. We did try this out at our institution, and it didn't work that well. The physicians actually didn't like the responses that the machine generated, and ended up most often not using them. It could also edit physician messages to optimize communication, for example, for literacy appropriateness. And in terms of documentation, the way that this works is the computer can draft progress notes in real time during visits. It could also do things like draft prior authorization requests, disability and durable medical equipment requests, which are very stereotyped. Could draft a list of billing codes for visits. There are many things that it could also do between visit instances. For example, helping accurately identify patients who are in need of cancer screening, using both structured and unstructured data to determine exclusions, identify patients with incomplete cancer screening and/or staff notifications. In addition, it could generate tailored messages to patients related to needed between care visit needs. And it could also help some with individualized decision support, for example, with relevant information in unstructured electronic health record data to help prioritize differential diagnoses for new symptoms, or recommend specific medication options for patients with chronic diseases. In addition, clinicians are going to need to know how to utilize AI, and this is a trust and value checklist which we put forward for clinicians, which I think applies to primary care physicians. This is work that I did with Christina Silcox and Susan Denser, and we suggested that questions that a provider should be asking if they're using AI is, does this use of this CDS or software lead clinically important improvement compared to the status quo? The answer is no, you can move on. Second, does the use of this software fit into my clinical workflow and or my team's workflow? If it doesn't, again, that's not going to work for people. Third, what information does the CDS supply at the point of use about the logic behind the decisions or recommendations that it produces? And the certainty also, degree of certainty that these recommendations are correct. Often that's not provided, and that's a really helpful thing to know clinically. Then it's also helpful to, if you can, know some about the data behind the CDS system. So what was the source of the data used to develop and train the software? How are the training data labeled? And does the AI-enabled software appropriately respect privacy? Particularly important are testing. So does the software fall under the FDA's regulatory authority? And if so, has it been cleared or approved by that agency? And if not, and most software that we use today that involves AI has not been cleared by the FDA, how was it tested, against what standard, and by whom? And in addition, has this AI-enabled software been tested on data from my own hospital or healthcare system? Typically, these models perform less well, when used in a new system. And very importantly, and often neglected, is how are the software being maintained and improved over time, and what provisions has the developer made for monitoring and updating that software over time? A few additional reflections. I think AI is going to likely be a team member and not a replacement for physician work, at least for the foreseeable future. AI, as Dr. Greenhall suggested, is much better at some tasks than others. So particularly simple tasks or summarization. And notably, these tools are constantly improving. So they are getting better all the time. And that's a little different than many other things that we're used to. Eric Topol has suggested that where we might be eventually, and this is a fairly utopian, futuristic vision of things, is the computer could be taking and summarizing data about an individual patient, including a host of inputs. So their social and behavioral information, genomic information, data from sensors, data from the immune system, and so on, and putting that all together and giving us personalized recommendations. We're still quite a ways from this vision, but I think that is where we're headed. This should help us to deliver truly personalized medicine. And a few reactions. There are lots of opportunities to leverage AI. We've got to work and see which ones actually work well. Ambient documentation does seem like the first big win. Generation of messages to patients, as I mentioned, hasn't worked out so well so far, but there are just a ton of other opportunities. And to wrap up, I would suggest that AI and machine learning are transformational, and medicine has really been late to the party. There are many use cases for it in primary care. I've gone through many. Image evaluation is personally the farthest along. In making decisions, the human plus the machine almost always does best. That will help a lot with our efficiency in the near term. It's absolutely essential to test the performance of models, and external validation in a new site is critical and is often left out. So companies will come to you and say, well, we have this model which works wonderfully, but then when it's tested in your own data, it may not work as well as they have suggested. I am really excited about the potential of large language models, although I agree with Dr. Greenhall that that's largely unrealized to date. But down the road, I think that many of the improvements that we see will involve leveraging multiple technologies like AI and big data and sensing and communication, and putting all those things together as we deliver care. So I will stop there and take some questions.
Yeah, no, thank you, David. We will open up the panel after the next speaker too, but one question for you to reflect on.
Yeah,
and you kind of nicely put it on the summary slide saying that humans are not going to be replaced anytime soon. But one of the conversations in the AI value proposition we hear a lot is primary care and the primary care physicians could be replaced by smart AI technologies, because in some people's assumptions, primary care mostly does diagnostics and like a checklist, and it could be done by AI. And then the follow-up cares could be done by allied health professionals. There's some really interesting papers on economics of AI in healthcare, and they kind of talk about this. What are some of your reactions to this? Do you see primary care going anywhere with AI, or primary AI becoming just as a tool, not as a replacement?
I think it's going to be a tool and not a replacement. I mean, I do think we'll have many more allied professionals in primary care. We need that. We just don't have enough physicians. But I think that AI will be a tool and will not be replacing people anytime soon.
Thank you, David. And that brings us to our third panelist, and a Canadian star in health informatics. So I'm pleased to introduce Dr. Tracy Risling. She is the president-elect of the Canadian Nurses Association and also the Associate Dean of Innovation at the University of Calgary. She has done research in nursing and in medical informatics over the last several years and has been a nurse professional. So she'll bring a very different and important perspective to this dialogue about how the nursing professional and the AI and the technology tools could actually help think us reimagine primary care. So Tracy, the floor is yours.
Thank you so much. It's such a pleasure to be here. I think that should be a full screen view of things. Is that what's happening there?
No, I could, now it is. Thank you.
Okay, perfect, great. I'm happy to kind of clean up here, and this section apparently brought to you by the letter P as we talk about what's possible, which I really think we've had a great overview of, but I really want to talk about people, preparedness, and the planet as well. So I think I had an opportunity to give a couple of chats about AI coming off the top into the early days of 2025 and some really interesting predictions. And it's kind of interesting to look back at these predictions that were made either in December of 24 or January of 25 and think about how much has already changed. And that is just very typical in the pace of AI. We really have a lot of talk about AI agents, a lot of security and privacy issues, and a lot of issues about trust. And again, there was already coming in to the start of 2025, I think a really important and renewed focus on the environmental impacts of AI. But let me put this back into this nursing context and talk about the possibilities. I really appreciate Dr. Bates' commentary on AI scribes and ambient scribes. And there is a lot of nursing-led research and work in this area as well. I have to say, natural language processing, I think, was something to celebrate in terms of nursing visibility in digital health and in AI. I think nursing has had a long history of truly invisibility in the electronic health record, which was driven by other language. And it was really hard to capture some nursing intervention and the way that nurses lead team-based or primary care that is much more capturable with natural language processing. And we're seeing some really interesting kind of visibility. I think in the recent event that you were at, Abby, about at AMS, and we were chatting about this ambient scribes, and the importance of this, of course, is that you provide care out loud, so that physicians provide care out loud, and that there is a bit of a movement in nursing called to nurse out loud anyway. And this has actually been a long-standing conversation for nurses because the visibility and the science of nursing, again, has not always been at the forefront. And so either this ambient scribe possibilities will give us new opportunities and new incentive to nurse out loud when we're at the bedside or at team-based care and leading care and doing these kinds of assessments and providing care, or, right, it will be another opportunity to us to reflect on what are the challenges of this for nursing and in the nursing patient relationships. I think for me, when I think about possibilities, I'm most excited, although we're seeing, some exploration of these things in Canada within nursing and transdisciplinary healthcare research in all of the kind of the top 5 there. I think what excites me most is the opportunities for patient engagement and education, personalization, and also clinical education for all healthcare disciplines. Now, the nurses in the crowd are going to recognize likely this. This is Patricia Benner's novice to expert theory. And when we come to fears about the robot nurse, or AI replacing nursing, it's important to note that so along the bottom here, you kind of have the ongoing evolution of where AI is at. And I won't go into all the technical jargon there, but let's just put up this hard line about what AI is currently doing in the nursing view in actual clinical practice, and then, you know, where it would need to go. And so we're very far off. What we have now is at best some novice, advanced beginner type of AI function, but we certainly don't have independent, proficient, or expert AI function. Certainly not that replaces, you know, some of the nursing intuition or judgment or other pieces that we see in care. I reached out to one of our Doctor of Nursing students, Irene Sorosa, who's doing an NP clinic work, is the director, NP program director at the Ingram School of Nursing, to ask about the use of AI right now in the moment on the ground. And these are her reflections about the use of these tools to facilitate workflow. Some really successful work with language interpretation. So again, what I see here is this potential for personalization and for connectivity and a bit of reduction of administrative burden. Canada Health InfoWay does some great snapshots. So we're going to shift to people now, chat about people a little bit. And Canada Health InfoWay does some great surveying of physicians, of nurses, and of citizens when it comes to all things digital health, but AI included. Here's a little look at the doctors' latest results on their survey on how they are seeing AI use in physician practice. And kind of what the priorities for that are. So a lot more policy, guideline, regulatory support. You can see that the digital transformation of the healthcare systems continues to be, and again, that training and education. And we're going to come back to that part when we hit the preparedness discussion in a couple of minutes here. Here's a snapshot of the nursing views. I really like this. It's very interesting to see. What we have here is a low use of nursing perspectives of the use of AI in care, and some higher knowledge of AI and potentially how it could be used to provide support and solutions, including in primary care. But we also see a learning need here. And then the citizens. And I love this question because it speaks to their comfort. And I'd like to chat a bit about trust before I leave this discussion with you today. But there is a high level of comfort, at least in this survey by Canada Health InfoWay for citizens with the use of AI. But I wouldn't say it's a wholesale 100% agreement, kind of an all-in feeling about how artificial intelligence is going to be used to support the health of Canadians. All right, we're hit preparedness now. Eric Topol has already come up, and we still go back to this 2019 report for the NHS, and the same year that Deep Medicine came out talking about the possibilities of this technology. And I actually find it really interesting to reflect about whether or not we're making progress in making healthcare human again with the use of this technology, or whether or not we're having techno stress and a lot of pilotitis and a lot of challenges related to this. But I do say, in a shout out to the UK and the NHS, they have done some really interesting things. I think that Canada and other countries could learn from well in providing supports and opportunities, not just for the training of clinicians prior to entry in practice, physicians, nurses, pharmacists, and others, but in ongoing professional development opportunities. And I think when we talk about preparedness, if we want to advance AI in primary care and in healthcare in general, there has to be an opportunity for practitioners to be able to learn, to engage, not just in the co-design of these, but in really their own competencies, comfort, and use of these technologies. The International Council of Nurses is on board and really providing a global voice around what nursing needs and what nursing can contribute to the advancement of digital health and AI. really calling on that health equity, people-centered approach. And I think, again, that's critically important and something that's really echoed in the primary care context as well. Here in Canada, the Canadian Nurses Association and the Canadian Nursing Informatics Association also recently released a position statement about what nursing practice looks like in digitally enabled care environments, including the role of AI. Again, I speaking to that dual purpose of nurses not only, taking up and using this technology, but being engaged in the design, the implementation, and the evaluation of it. The Canadian Association of Schools of Nursing recently released their second edition of Entry to Practice Competencies for Registered Nurses. And this year in this edition also includes some mention of and the importance of nurses, all nurses, whether they be primary care, nurse practitioners, or registered nurses, having a strong foundation in informatics, including knowledge of and ability to evaluate the use of AI tools. I want to harken back for a moment to some work we did with RNAO and AMS Healthcare over 4 years ago now, where we talked about the importance of nursing and compassionate care. So again, uniting the science and art in the application of these technologies. And I won't read through all of these. So this is the 8 recommendations that were made. And here's my little report card update of where I think things are at today. So these kinds of dialogues are fantastic when we continue to talk about how AI health technologies will influence all kinds of care, but really new care delivery models. And I actually think that primary care has the opportunity and possibly the responsibility to be a leader in terms of really delivering on what do these new care models look like? How do we integrate this technology into this team-based approach already? So I think there is a really incredible opportunity there to see that. We are behind. I think Dr. Bates alluded to the fact that medicine was a bit late to the party. I think when we look at curricula and perhaps the NHS in UK is ahead of where we all are at. But I think here, the biggest thing that we can focus on is thinking about providing opportunities for curricular development. And when you look at priorities that nurses have to support their use of AI in practice, you can see that sentiment is shared and that appropriate training and education really tops the list there in terms of very high priority. What do we need, though? I think it can seem really overwhelming. I think for all kinds of healthcare practitioners who, especially when we talked a bit about burnout and tech fatigue and thinking about the capacity to develop what seems like perhaps at first blush an entire new set of competencies. But really what we're talking about here, there is a small element of the technical competencies, of course, especially when it comes to AI. But I think what we're really talking about is a bigger picture of social, ethical, and clinical competencies. And how I usually like to think about it is what we're talking about, especially for nurses, is adding on an element of education, training, and competencies that is more the cherry on the top of an incredibly important, robust skill set that will be essential to the equitable, the just, the effective, the sustainable, scalable use of AI technology in healthcare systems and in primary care. There's lots of frameworks and competency work coming out to support this. Really a lot of work being done in Canada right now. So I think I have a few minutes to hop to the planet, and we can go back to Eric Topol and Kate Crawford, two American gurus of AI. This is actually from a bit ago now. In 2021 already, Kate kind of raised really a huge flag about the use of energy consumption and water consumption by AI tools. I would like to say that this is getting better, and there's some really interesting things like perhaps nuclear fusion will save us and save the demands, the environmental demands that these kinds of technologies are creating. But right now, that promise is not here, and the climate demands and the environmental impacts of this technology continue to increase. There is a really great new a very recent piece in Nature about what is the actual, how do we actually measure and capture the impact of these tools on the health of the planet. And I'll be happy to throw that link into the chat at the end. Really some really interesting planetary health and nursing leadership in this space, where we think about, sorry, I'm just hop back, where we think about, you know, the need, I think, as healthcare practitioners, as primary health care practitioners, there is a critical need to balance the health of the planet with the health of our patients, our communities, and of course ourselves. So it kind of gets very overwhelming in the end, and you start to think, how would you possibly, as any one clinician, as any one practitioner, come to evaluate any single AI tool or solution about whether, you know, it's useful to you, to your practice, again, to your patients. And I think one of the things that we're doing is taking this more holistic view, again, very common approach within the primary care sphere as well. This again is another old nursing theory. It's the nursing meta paradigm, and we're just finishing a checklist now about thinking about person, nursing, health, and environment, and how if we can't secure wins for any one AI solution across the board in all of these things, then it's not a win for nursing, it's not a win for primary care, and it's not a win for the health of Canadians. And it all really comes down to trust. I find when we talk about AI and trust, there's some really interesting, there's a couple of great recent surveys released in Canada about how Canadians trust AI. So I'll sum it up for you by saying we either trust AI too much, for example, as a reliable news source, or we don't trust it at all. And there's problems on both sides of that. And practitioners, nurses and physicians and other folks in our allied health teams fall along those same lines. So either we have no trust, or we have too much trust, or there's a mix in between. But trust is really key. And you can see this is back to the InfoWaste survey and what citizens are thinking when we talk about using AI in healthcare. Thinking about privacy breaches, thinking about inequalities, thinking about the loss of human interaction. And these are trust and relational issues. And again, nurses feel the same way, the loss of human interaction, data and security and privacy concerns. So at least when it comes to this technology and how to move things forward, we are on the same page quite a bit as a team. This is a group that I have the pleasure of working with, the AI for Public Health CIHR-funded training platform. This is an interesting report which echoes this trust, collaboration, and the need for both data infrastructure and skills and training to advance AI for the good of health in Canada. And I think I'd like to leave with a thought about collective intelligence. And there's been some discussion already about AI as a partnered tool or an intelligence amplification tool, as in the work of Goldberg. But there's a really important consideration about us working together. And this just came out this week from Louisa Jarofsky. If you don't follow or have her newsletter arriving in your inbox and you have a passion for AI, I highly recommend it. And this week, she really highlighted AI's literacy crisis, the fact that it moves too fast, that it will leave people behind, even folks who think they are tech savvy now. So not only do people not have access, but even those who do have access, their ability to use and understand them, to evaluate them, is going to not keep pace with what the AI itself, how the AI itself advances. And I think that this was really kind of a terrifying moment for me this week in this space, even thinking about preparing to be here in this conversation today, is that it is the absolute imperative for healthcare professionals. And I think, again, that primary care is an ideal place for this, to watch for AI literacy and for AI have-nots and to think about what is our role as practitioners to support everyone, including patients, to be able to really maximize the use of AI for better health. This is a comment. Again, I reached out to Dr. Ivy Danson about the use of AI in primary care, past co-lead of the Team Primary Care Initiative here in Canada and a family physician. And I couldn't sum it up any better than to think about AI not being a replacement for people, but that it has to be a way that we stay connected, not only across primary care teams, but with our patients, with our communities, and use these technologies as a way to ensure that patients do not fall through the cracks. It really has to be about the person-people connection. And at the Canadian Nurses Association, this is part of our federal election platform. We're in the middle of a federal election campaign right now. And again, the value of nurses in primary care, but also highlighting the importance of AI in this, in advancing team-based care and advancing the opportunities for connectivity. Again, not just between the practitioners, but between ourselves, our communities, and our patients, and as a way, hopefully, to equalize patient access to data, for example, or more importantly, using it as a tool to help patients understand that data, to be supported in the steps they need to take to really maximize their own health. This is a short piece that Dr. Gillian Strudwick and I did for the Canadian Nurse, talking about, again, that maximization, how we feel that nursing can contribute to the advancement of AI, not just in primary care, but across our health systems. And it, I hope, sums up and echoes some of the themes I've tried to touch on today. I draw your attention as a shout out to Healthcare Papers. There will be an edition, a special AI edition coming out about healthcare in Canada. And again, we had an opportunity to write the nursing response to this interdisciplinary issue. I'm very excited for this issue to come out. I think it's going to be a really great read and a great resource. Essentially, spoiler alert, how we summed it up for nursing, again, is about capacity and competency. If AI is going to free up time, then I truly hope, sometimes when we talk about AI in nursing or in healthcare in general or in primary care, we talk about, well, this will give us more time, for relationships or more time, to do that kind of person-to-person care that again, primary care is the heartbeat of primary care. But I have to say, if it frees up time, and if I could just speak for nurses here, then I hope it actually frees up time, because there is an overburdened workforce here that a sense of stress, of burnout, right? So if AI is going to free up time, can we first think about how much time is needed for the health of our healthcare workforce? And then once we've established that, is there time then to give healthcare practitioners an opportunity to learn more about AI, how to really use it, how to help patients use it, and how to move the technology forward again? So it's not something you want to turn your back on. It moves pretty quick. It's controversial. People have some concerns. This is a list of common searches of AI in the last week, right? It still raises concerns that we'll all see in practice and in conversation with patients and practitioners about advancing this technology. I'll leave you with this last P. I couldn't resist. Sorry, I had to stay on theme, that the integration of AI or the advancement of AI in healthcare has to be a team sport, and primary care is already one of the most ideal examples of that. And so I think, again, a real opportunity to be leaders in the advancement of this technology. Thank you so very much.
Thank you, Tracy. That's a really nice summary of the different P's that you talked about, and all essential P's. I wanted to ask you a question about the team part that you talked about. So the reality is, in the next years to come, we are going to have a new healthcare team member, the AI clinician, whether as a tool or as a decision support system, it's going to be part of that healthcare team. But how do you see that team is going to change the way our current care models are working? Like you touched on some of the care models too. What are some of the changes we need to think about right now, especially in primary care around these care models?
Yeah, I think it is a really important consideration. I want to share a nursing view to maybe respond to that in one way, which is to think about the difference between evidence-based care and evidence-informed care. And I think about when we think about AI as a new team member, and again, I think that when we think about nursing and primary care, we see this example of evidence-informed care. So if you take evidence-based care, you take the best, the gold standard evidence, and you apply it, this is a gold standard in healthcare practice. When we think about evidence-informed care and we think about AI, it's a really lovely combination because evidence-informed care is taking all of that best evidence and then looking at the person, the situation, and the context in front of you, and then applying it. I think it's a much easier way to integrate AI as a team member and as a support when we think about advancing evidence-informed practice, as opposed to, kind of that across the board implementation of evidence-based practice. So I think that that's how we're going to see it. But I think these literacy pieces, like providing opportunities for everyone to be on the same page, there can be no team without that. Then it's always just hierarchy. So I think that the digital determinants of health that need to be addressed, if we don't address those, then team is going to be a big reach.
Thank you. That's key, like the digital literacy and the digital determinants of health, right? So we normally talk about the social determinants of health, but the conversation needs to really think about some of the digital determinants of health here as well. I'm going to invite both David and Trish to join as well for the panel discussion. And the participants, if you have questions, please use the question and answer function to post the questions. Let me start with the first question I have here. Is this one. Will the expectations and readiness for task shifting and technology integration differ for the new generation of health professionals who are coming through our system, who are so used to digital tools and AI? How can the system support this next generation of health professionals to embrace technological advancements while preserving the essential human elements of care? So anyone wants to take this one about the next generation who's going to come? They're tech savvy, they are AI savvy, and they want that in the system. Trish.
Okay, so I'm really, really old. Okay, I've got my bus pass. I've got my old age pension. I learned computer science at school. I did programming at school 50 years ago. This idea that people of my generation in their 60s didn't learn about computers and digital stuff. Oh, sure, we learned old stuff, but this idea that there's a new generation. The other thing is that the new generation learns certain types of skills on digital tech. They're really good at gaming, for example. They're really good at carrying on their conversations with their friends as they kind of disappear off in different directions. But actually, the use of AI, digital tech for their job, I have not found the new generation to be any better than the old generation. I think it's another thing, like just around the corner, everything's going to fall into place. Oh yeah, if we only wait for the next generation to come through, they are tech savvy. I don't like this word tech savvy because what does it actually mean? Well, it doesn't, I can use some tech really well, and I'm absolutely rubbish at other tech. So there is no such thing as this generic tech savviness. It does not exist. I was thinking, if this was a drug, we would be saying, where's your evidence that it has improved outcomes? Not, oh, we think if you take this drug, it might improve outcomes. So let's all rush off and prescribe it. It doesn't work like that.
Yeah. I think, David, you had your mic, and then Tracy.
Sure. I mean, I think it's really the generation before that's Trish that struggles with this. So my mother, for example, is 91 or 92 now, and she does have a little trouble, for example, interacting with her electronic health record. But we can help her um, deal with that. I think it's going to take time for people to get used to these technologies and figure out how it fits in within their workflow and what works well for them and what doesn't. Um, um, but I see that as happening going forward.
Tracy?
I mean, I have to echo Trisha's thoughts. Digital native is a phrase I could abolish easily. I mean, I think, this is also a generation that has been subjected to the horrors of their digital world over and over and over again and seen unprecedented impacts on their mental health. And, I didn't, but we are working on a large project about mis and disinformation, not only its impact on the health of people, but the AI generation and the bad actors that are engaged there. And so I think, if anything, the generation is wary, I hope so, appropriately wary of the risks and the so I think, and again, if we come at it from that team-based focus and that kind of equity lens, I think it's about meeting people where they are and having conversations, right? Conversations. I had a great comment sent to me about people first, patients first, and 100%. It has to be people first, technology second. We need to have conversations about where this is going to work, how it's going to work, and what people want. And then continue on with the kind of co-design, evaluation, use, and uptake of this technology. Otherwise, it will ebb and flow and come and go, and it won't become a foundational part of how we provide healthcare or how we connect with people, because it won't have been, designed with and for people.
Thank you. So the digital question and the generational question is kind of interesting one, but I think like Tracy, you had a really nice image where you showed the facing the back and how the storm took over the person. It's the same thing. The generations are going to evolve. The technology is rapidly evolving, so everyone has to keep up with this one. So the next question, kind of shifting from the providers to the patients. So the question asks, assuming that speakers agree that patients and the public should be actively engaged in the design of
No
both
problem.
AI.
You're done?
Sorry, someone's microphone is on.
We're all here.
So they ask, assuming the speakers agree that patients and the public should be actively engaged in the design of both AI tools as well as the governance of AI, how can patients and public members be systematically and practically and authentically be involved in AI integration into primary care? So what's the role of patients in AI? Tracy, do you want to take that up?
Yeah, I was just thinking about the work of Healthcare Excellence Canada has done some incredible work on the engagement of patients and AI. And, I think it just echoes what I was just saying in the last comment, which is that this has to be people first. There has to be a collaborative, kind of co-designed approach. And that, again, to re-echo that idea of evidence-informed practice, technology cannot be something that keeps happening to people, right? Nurses have a long history of technology happening to them, and I would say patients as well. And I just feel like this is a moment for us to use the advancements of this technology that maybe would, allow for more efficient, right, involvement and engagement of others to do it different this time, right? I mean, I think we could get a lot of folks to provide a lot of commentaries about what happens when EHR happens to people, right? And how technology is improved, the more people are engaged in its design and its use and its ongoing evaluation and implementation.
Risha?
I mean, on one level, I agree with everything Tracy said. One of the things I've been worrying about with patient involvement, I mean, nobody could get up and say we don't want patients to be involved. We all have to want patients to be involved. Of course, it's a given. The problem is actually the same. Someone was asking a question about training data sets on the wrong populations and missing out, all the people who at most need. It's exactly the same with patient involvement, that we tried to get our participating practices to involve patients in the design of workflows and the kind of embedding of tech in those general practices. And they just didn't have time. The techno stress was too great. And they were really worried that if they got the patients involved, the patients would say things like, we'd like you to make the telephones work better, and things. And they didn't have the resource to do that. But the one or two practices that did have patient involvement groups, guess what? Sorry, Tracy, they're all retired nurses. And they were mostly white. Now that some of my best friends are retired nurses, don't get me wrong. But actually, the people we found had real access problems were, some of them were young guys in their 20s who were autistic and almost homeless. They were sofa surfing. And not only did they not have a computer, but they didn't have a home. But also they were kind of slightly stroppy and they kept getting kicked off the premises. You try getting that kind of patient involved in co-design, you can't do it. And so what you end up with is the same biases in patient co-design as you get in the algorithms. Now, that's not to say we shouldn't do it, but I think we really, really have to not just involve patients, but think, how can we capture the perspective of the most disadvantaged patients and feed that in? And actually, I'm a great lover of ethnography for that. Ethnography and building relationships with community centers and the people who really know about disadvantaged groups, whichever disadvantaged group you're talking about. So I think it's actually trickier than you think.
We've done some work on apps and found that most of the apps were designed without any patient involved and often without even a provider involved. So no wonder they don't work for people when you go ahead and do it. And we did some work with disadvantaged patient groups and found that essentially every one of them wanted to be able to use the tools. But for example, half of the diabetic patients could not even figure out how to enter their own glucose, which is about the most basic task. So as Trish is saying, things have just we've not done a good job designing things for groups like that.
Thank you. I think all three of you touched on the engagement of patients, and there's additional questions about someone who just shared something about in Canada we have, and especially for Indigenous health professionals, dealing cultural safe care is an essential thing, like not only for Indigenous population, but all the different cultural populations. We struggle with providing culturally safe, appropriate care. So how do we ensure that AI and the LLMs are going to be taking these cultural variants into account so that patient safety, patient-centered care, all of those things are provided? Any thoughts on that? I mean, it's similar to patient engagement, Trisha.
Well, potentially the large language models could do really well here. I heard about a woman who had two autistic teenage sons and didn't really know how to get things across to them. And so she used to type into one of these, Chat GPT, I want to tell my sons this, but please can you express it in a way that my autistic kids could understand? And ChatGPT would then rewrite it, and she would then, she'd then read it out to her kids. Now, I think you could do the same. I heard you could do the same if you were having a French guest to dinner. What should I do for my French guest? The ChatGPT will tell you how to adapt things, that kind of thing. The problem with that is, I think racial and cultural stereotyping. And so the best thing you're going to get is something that is statistically representative of a particular cultural community, but that individual may not fall into that stereotype. But maybe that's better than nothing. I don't know. It's better than no cultural competence. So I'm actually fairly positive about the potential for large language models. So I am being positive about something here. I'll hand over to someone else, see what they say.
Thanks, Trisha. Tracy, David, any thoughts on that? And I see
just wanted to mention.
Okay.
Yeah, no, I was just going to mention that we have had really great experiences with using some of these electronic tools to translate in real time, and somebody mentioned that. I think it was Tracy, but that I think that is a very powerful function of these.
Yeah, and I think it's my hope that, specialized, and there's a great comment in the chat about specialized, culturally specific LLMs. And I think in combination with AI agents, right, where you can have conversation, you can have it tell you what you most need to know. And Trisha's great example again about not just how to communicate, but what is the information that you need to know. And I think that there is a really high opportunity here. And so when we think about Indigenous ways of knowing, or, other opportunities to enrich, existing data sets or existing information that is feeding these, I think we need to look at the specialized development of LLMs that, what we see, out in the world with the chat GPTs and the Claudes and others, are large language, they're trained on the entirety of the internet and then perform accordingly, and frighteningly. But this specialized development, I think, is really an opportunity not only to stand in contrast. It's really interesting to ask a specialized large question and to ask the general. And there's some interesting research coming out. And I think that's one of the best ways to show the biases that exist between, right, these very large general models and some of the specialized work that's being done. But it's also a pathway forward for us to really harness the positive power of this technology for better representation, better engagement, and better opportunities. Lots of people like to have a conversation with these AI agents. It's nice to be able to ask, I think about going home with a brand new baby and thinking, did you just hand me this human right now with this, not just a stack, an entire bag of paper and all of this information? And I thought, it's almost impossible. If you could just have a friendly conversation with a specialized, right, curated, that delivers you the absolute information that you need to know, when and only what you need to know. You ask it, I need to know this right now. This kid is doing this, help me. And it will, and it can. And again, I think when we think about the context of primary care, and the breadth of care that's provided, like, this is the opportunity to think about how these tools can be used in this way to personalize care and to advance people's health.
Thanks, Tracy. And I think there's some discussions in the chat as well about some of the country-specific LLMs. So the sovereign LLMs are a big thing right now. Each country is developing their own LLMs for a number of reasons. So this is probably another way to think about how the health systems can adapt that. I'm mindful about the time, so I'm going to ask the three speakers to do a closing comment, basically thinking that we are having these exact conversations 5 years from now, and one thing they would have like to see change or improve in primary care with this digital AI transformation. So maybe I'll start with Trisha, and then David, and then Tracy.
Well, I'm quite inspired by the AI scribe stuff that David and Tracy were talking about. What I'd like to see is an AI tool that clears up the mess from not just the AI scribes, but the kind of AI's ability to take and generate and send text. Because the people we interviewed were spending a lot of time sorting that stuff out and filing it. So it's like, you create order in one part of the system, but you create disorder somewhere else. So I'd like to see the AI hoovering up all the mess and extra work that generates. And maybe it will, maybe it could.
Thanks. So thinking about workflows and optimizing the workflow processes. So thanks, Tricia. David?
Yeah, I'd like to see it do similar things. Basically, save providers time around some of the things that are mindless or rote, or that we should really not be doing, and having seeing providers spend time instead, say, communicating with their patients. I think that could make primary care, more satisfying than it is right now.
Thank you, David. Tracy?
Yeah, certainly I echo that. I think, everyone would like to see AI live up to its hype and promise, especially in the healthcare arena. I think there's some cautionary tales there. I think that we have to think about the bias that still exists in our data, in our systems, and that we don't amplify that with this technology, that instead, we make the effort that is needed to ensure that we are using it, right? And again, we talked about the digital determinants of health. That includes things like the digital divide. We don't want AI have-nots. That is not that is not the healthcare way. That does not continue to, we already have these problems in our healthcare systems, and we certainly don't want this technology to amplify those in the wrong direction. We want to be able to take it up and use these tools. But also, and again, I really like David's comment about, and again, the promise of this technology to give us more time to be together as humans. But again, I re-echo my comments about the stress and strain on the healthcare workforce, not just here in Canada, but around the world, and that hopefully these tools think about ways that can give these practitioners more time just to take a breath.
Thank you, Tracy. Thank you, David and Trish. Thank you, Tricia. This has been a wonderful dialogue, and I think the future is bright, but we also need good strategy and good oversight to make sure that we don't make the same mistakes that we have made with previous technology innovations happening in healthcare. So thank you for your time. And for all the participants, I have my contact there. If you have any follow-up questions, or if your questions have not been answered, please share it with me so we could reach back with you with some answers. And now I will invite Joe to provide the concluding remarks.
Thanks, Abby. Just as a comment, 5 years from now, I think our goal is to strengthen primary care and to redesign, restructure, and hopefully ensure that the issues that we're facing, access, wait times, and other structural issues, work stress, and so forth, are addressed. And if this can help, that'd be great. And I think what you've talked about certainly works towards that end. So thanks, Abby, and thank you for assembling such a strong panel and moderating so effectively. Once again, you get better every single time. By the 16th summit, you'll be unbelievable. I want to thank our panelists, Professor Trish Greenhalgh, Dr. David Bates, and Professor Tracy Risling for your participation. Our goal today was to provide better understanding of AI's role in strengthening primary care. And unquestionably, you helped us achieve this goal so effectively. Thank you again. Our appreciation also goes to Nidhi Sejwal, Krembil Center's Program Manager, for coordinating our summit so efficiently and with such meticulous attention to details. Thank you, Nidhi. And last but certainly not least, and I hope they're online, I want to acknowledge and express our gratitude to the Krembil Foundation for their continued support and enthusiasm. They have made this happen for us. Their collaborative approach in particular sets the bar for philanthropic partnership. Please note that our next summit, and we will be continuing, will be in the fall, focusing once again on the most salient themes in our sector. Please be assured that we'll be in contact with each of you. On behalf of the Krembil Center for Management and Leadership, thank you again for joining us. This meeting is adjourned.